Hypertension during pregnancy, case-based discussion. We have a case number 2. We took in the previous session case number 1. Now we'll have a second case. A 36 years old gravida 3 para 2 female at her 36th week of gestation is sent from her physician office to the obstetrical triage unit for elevated blood pressure. The patients deny headache, visual abnormalities, or right upper quadrant pain. She has no uterine contraction or vaginal bleeding, so she is asymptomatic apart from elevated blood pressure. On arrival, her blood pressure was 155/100, heart rate 98, temperature 37, and respiratory rate 12. On chest examinations, her heart and lung were normal. The fetal heart rate was normal with acceleration. There are no uterine contraction, and PV examination shows unripe cervix. Now, we sent for the investigation, and it was as the following. The hemoglobin was 10.5, which is low, although she is hypertensive. The platelets count reduced, it is 80,000 per cubic millimeter. The glucose is normal, and we will know why it is important to sense for the glucose. The SGOT and the SGPT was markedly elevated, even more than 2 or 3 times the normal, with a significantly high LDH, thousands, and serum creatinine level was normal. So we have moderately elevated hypertension with a low hemoglobin and low platelets count and markedly elevated liver enzymes. And because the LDH is high and the hemoglobin is low, so this may explain what? This may explain hemolysis that we will see it by the blood film. So, HELLP syndrome requires the presence of all of the following. Platelets counts low, less than 100,000. SGOT and SGPT elevated more than 2 times the normal. Abnormal peripheral film. LDH more than 600 international units per liter, and or bilirubin more than 1.2. So if we will see bilirubin high, it means that there is what? There is maybe what? Maybe hemolysis. So to have a HELLP syndrome, HELLP, H comes from hemolysis, and the diagnosis of it requires 2 of the following. Abnormal peripheral smears, we will see a histiocytes and Bartels. Elevated serum bilirubin more than 1.2 milligram per deciliter. Low serum haptoglobin, and significant drop in hemoglobin unrelated to the blood loss. So to have 2 out of these 4 is a diagnosis of what? Is a diagnosis of a hemolysis. Coming to the EL, we have elevated liver enzymes more than 2 times the normal. And with it, we have an LDH more than 2 times the upper limits of normal. Coming to the LP, low platelets count, we should have a less than 100,000 platelets per cubic millimeter. What is the most likely diagnosis? It is a case of HELLP syndrome. What are your next steps? First, we have to admit the patients to the labor and delivery units. We have to start magnesium sulfate as a prophylactic measure against convulsion. We have to assess and stabilize maternal conditions, particularly blood pressure and coagulation abnormalities. So we have to send for DIC screening parameters. And we have to consider the best options for delivery. It means if I have HELLP, I consider this is a case of severe PE and I should intervene. It means delivery is imminent after stabilizations of the maternal general condition. What additional lab tests are indicated at this stage? We have to send for DIC screening, and this includes the following: PT, PTT, platelets count, serum fibrinogen, and fibrin degradation products. The blood bank should be contacted for the possible need for blood products, although in this scenario, there is no overt signs for bleedings and coagulopathy, so there is no need to transfuse the women. The hemoglobin level and the platelets count should be monitored, and the platelets count should be above 20,000, so this is a very important number. to guard against spontaneous hemorrhage. And it should be above 50,000 if we need any surgical intervention. So 20,000 we should give platelets regardless there is bleeding or not, and 50,000 we should give platelets if we need surgical intervention. The clinical presentations of patients with HELLP syndrome is highly variable and is considered a variant of preeclampsia. That's why we have to search for it whenever we have a case of preeclampsia. Patient may present with non-specific symptoms or subtle signs of preeclampsia, so two hands. Not all women with HELLP syndrome have hypertension. 12 up to 18% of cases they will have a normal blood pressure. Generally, patients with HELLP, they are older women, multipara, white female, with presentations at less than 35 weeks gestation. Patients usually complain from epigastric pain, right hypochondrial pain, and GIT manifestations in the form of nausea and vomiting. Most patients, up to 90% of cases, they give a history of malaise for the past few days before presentation. And some will have non-specific viral syndrome-like symptoms. So that's why the presentation may be misdiagnosed. A subtle of patients with severe thrombocytopenia with it may present with bleeding from the mucous membrane and from the mucous membrane by mucosal surface, buccal mucosa. They will have hematuria, petechial hemorrhage, or ecchymosis. Whenever we handle a case with HELLP, especially if it was normal tensive, we have to consider a differential diagnosis of it. So, the differentiations among HELLP, acute fatty liver of pregnancy, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome is based on specific laboratory finding and only slight differences in clinical presentation. An effort should be made to attempt to identify an accurate diagnosis given that management strategies may differ among these strategies, or these conditions, sorry. Start with acute fatty liver of pregnancy, how the patient presents. They present with, again, nausea, vomiting, abdominal pain, but they will have obvious yellowish discolorations of the sclera. Most patients will have prolonged PT, PTT, low fibrinogen, and we have a serum glucose. That's why we sense for it as a baseline investigation. Second, we have thrombotic thrombocytopenic purpura. It is rare during pregnancy and characterized by a neurological manifestation with or without fever. They have by lab test severe thrombocytopenia, severe hemolysis with a very low hemoglobin. So the hemoglobin will be significantly low. And the liver enzymes here will differ from that seen with HELLP syndrome. It is normal or slightly elevated. Coming to the last differential diagnosis, which is hemolytic uremic syndrome, and usually they will have a renal failure, and most of the cases they develop this complication postpartum. How to manage? Immediate delivery is indicated in patients more than 34 weeks of gestation. So if we diagnose a case of HELLP and she is more than 34 weeks of gestation, delivery is indicated. If she was less than 34 weeks of gestation, we give steroids, then delivery is planned within 48 hours after stabilization of her general condition. Because of the significant morbidity and mortality associated with HELLP syndrome, expected management past 48 hours is generally not advised, so we have to intervene within 48 hours. The presence of HELLP syndrome is not an indication for immediate delivery by cesarean section. It means still there is a place for vaginal delivery. So if the cervix is right, we can go for induction of labor. Especially if she was what? Especially if she was above 30 weeks of gestation. If she was above 30 weeks of gestation. If she was less than 30 weeks of gestation, usually the cervix is unripe, so we can use induction by prostaglandin or better by cesarean section after stabilization of her general condition. Indications for immediate delivery if it is extremely premature, 34 weeks and above, less than 34 after giving corticosteroid, immediate delivery, even less than 48 hours if we have fetal distress, and less than 48 hours if we have maternal distress in the form of eclampsia, associated DIC, adult respiratory distress syndrome, and suspected liver hematoma. So time limits here is less than 48 hours. It means imminent intervention. Now, coming to the mode of anesthesia. Consultations with the anesthesiology team is warranted. Epidural anesthesia should be used with caution. Why? As many anesthesiologists are reluctant to place an epidural catheter with a platelets count less than 75,000. So again, this is a very important number. Any count less than 75,000 is a contraindication to do or to insert epidural catheter. So, general anesthesia is the method of choice for cesarean section in severe thrombocytopenia. The use of pudendal block is contraindicated in the setting of HELLP syndrome. So, epidural catheter the platelet should be above 75, less than we consider general anesthesia, and pudendal block is an absolute contraindication. Platelets transfusion is indicated either before or after delivery in the presence of significant bleeding by skin and mucous membrane manifestation. The platelets count is less than 20,000, and if we want to intervene surgically and the platelets count was less than 50,000, we should give 5 to 10 units platelets, 5 to 10 units platelets, if the count was less than 50,000. And always remember that in HELLP, there is a rapid consumption of platelets in these patients. So, once we consider surgery, we give 5 to 10 units platelets. The surgeon should consider placement of drain, whether we put it subfacial, subcutaneous, or even both. Why? Because of continuous oozing. The risk of hematoma formations without preventive measures, one of them is a drain, is approximately 20%. That's why to put the drain can decrease the possibilities of hematoma formation. Postpartum management of HELLP patients should include close hemodynamic monitoring and serial laboratory evaluations approximately every 6 hours for 48 hours. Generally, most patients show resolving disease process within 48 hours post-delivery. So how we monitor? Every 6 hours at least for the first 48 hours. How frequent we send for the investigation? Every 6 hours for the first 48 hours. Now, suppose DIC concomitantly presents or it occurs as a complications of HELLP. What to do? DIC may complicate HELLP syndrome and is a serious condition. Definitive therapy for DIC is removal of the initiating factors, and in HELLP, the initiating factor is a pregnancy, so the definitive therapy is delivery. What to give in DIC women? Fresh frozen plasma. The unit contains 250 ml. It will correct PT, PTT, and fibrinogen. We give 4 units simultaneously initially and then as needed, putting in mind that each unit increases fibrinogen by around 5 to 10 milligram per deciliter. What about the cryoprecipitate? The volume of it is small, 35 to 40 ml. It is very rich in fibrinogen, and it will utilize less volume than fresh frozen plasma. When to give it? If the serum fibrinogen is less than, if the serum fibrinogen is less than 100 milligram per deciliter, we should give it. And we should give it if it is less than 150 and there is hemorrhage. And each unit again will increase fibrinogen by 5 to 10 milligram per deciliter. So the same amount increase but with less volume. What about the platelets? As we said, the transfusions, always remember 20,000, even if there is no bleeding. Now, if there is a bleeding or if we want to do cesarean section, the cutoff level is 50,000. So we will give if it is less than 50,000. Each packet of platelets increases the platelets count by 7 up to 10,000. And always remember that, as in health, rapid conception of platelets is there in DIC condition. Coming to the packed red blood cells, to give it will increase the oxygen carrying capacity. And we have to always to keep the PCV above 25. And we have to follow for electrolytes and hemolysis and red blood cells transfusion. Why? Because it will lead to what? It will lead to hyperkalemia, that it needs correction. Suppose we will have a subcapsular liver hematoma because of the disease per se or because of complications of HELLP syndrome. What to do? Management of contained hepatic hematoma should include close hemodynamic monitoring and checking coagulation status. The patient should be supported with volume replacement and blood transfusion as needed. If the size is small and the laboratory abnormalities are resolving, the patient may be discharged with outpatient follow-up. Avoidance of abdominal palpations, convulsions, or even emesis. Why? To prevent increased intra-abdominal pressures, and this may cause rupture. A ruptured subcapsular liver hematoma is a surgical emergency and should involve liver trauma surgeon and vascular surgeon. It usually involves the right lobe, corrections of coagulopathy and massive transfusion of a blood product is essential. The maternal and fetal mortality is very high, reaching up to 50%. And the current recommendations for treating rupture of subcapsular liver hematoma in the pregnancy is packing and drainage. Key points. Don't use dexamethasone or betamethasone for the treatment of HELLP syndrome per se unless we give it for a premature baby below 34 weeks, as we said. In women with severe preeclampsia, limit maintenance fluid to 80 ml per hour unless there are other ongoing fluid loss, for example, hemorrhage. Thank you so much.